And with this supplement industry, the other part of it has also been things that are not studied in terms of like a material safety data sheet, in terms of a chemical compound or a risk benefits sheet that you get from a pharmacy. I've had, unfortunately, a couple cases during my training and afterwards where patients bought a Dr. So-and-so's something fluid or prevent COVID, prevent flu, and they ended up on dialysis because of what they were taking.
Jeez. Welcome to Dive into Health MD, the podcast where we explore how everyday habits shape your physical, cognitive, and financial well-being. Through conversations with physicians, scientists, and farmers, we explore how daily choices like food, movement, sleep, and mindset shape the health and life we experience, with special episodes on sourcing high-quality food ingredients. We do our best to stay up to date, and we're always open to refining our thinking as new knowledge emerges. I'm your host, Dr. Jiten Mehta. Let's dive in. Dr. Jiten Mehta, thank you for coming in to Dive in Health MD. I am so excited to chat with you. We've been talking on the side, and there are so many topics I feel like we can explore. Start off, do you want to tell people who you are and what you do?
Sure. So I'm a nephrologist or kidney doctor. For anybody watching, a nephrologist means a doctor of the nephron. Nephron is the functional part of the kidney. You have about 1 million nephrons per kidney. So my goal is to try to save your nephrons on a daily basis. My job function in private practice consists of ICU level kidney care. So those patients coming in whose kidneys are acutely injured, following up with patients in chronic kidney disease clinic for management of chronic conditions anywhere from lupus nephritis, so those patients with chronic lupus that has affected their kidneys, down to what is the most common, which is diabetic kidney disease. And that makes up actually about 70% of my clinic. And then the last part of my day is involved with dialysis and working on patients getting home dialysis, peritoneal dialysis, and in-center dialysis, and hoping for as many of them as they can to get transplants. Outside of that, I carry a couple hats at the hospital. My favorite one is the rapid response ICU care team, helping with education and assisting with those patients who we hope to prevent from being too unstable. And with that, with drug toxicity education and other factors that I do. So yeah, that's my day to day, but otherwise I'm from Southern California. I never left besides going to Arizona for med school. And I came back here for all my training. And yeah, it's a great gig. I love what I do.
Full scope. That's so much to take on. That's so much to handle. If someone followed you around for 24 hours, what is something surprising that they might see?
How much I focus on sodium and urine protein. Two
Okay.
factors that people don't necessarily associate with your kidneys, but two factors that are very important for your body. Sodium, many people recall in terms of hypertension, right? Low sodium diets, trying to be healthier, avoiding highly processed foods. But in the hospital setting and in the clinic setting, we have sodiums that are too high and too low. And sodium being the most bioavailable cation in your body helps just about all your organs do their job, from your brain down to your muscles and your vascular system. Sodium is important. Any tick away from normal can affect everything that you do on a daily basis. So that's one thing that maybe you don't suspect a kidney doctor to worry about. And then urine protein. Protein, as has been discussed here and is readily available on all platforms of social media, is the new part of nutrition that everybody's focusing on. That's not my role. My role is if your urine is leaking protein, and that being a sign of some form of acute or chronic kidney injury, and preventing that. Because typically, if your kidneys are doing their job, you maintain or retain 99 to 100% of all protein in your diet. So if it's elevated in your urine, something could be macroscopically wrong with your kidneys. I get called.
Amazing. So when are times that people should be looking for that or testing for that?
So the most common reason why a patient may either self-refer themselves to my clinic is in the context of protein is when they see foamy or overly bubbly urine. And if you Google that, that is aligned with elevated urine protein. That is sometimes true, sometimes not. And many times a patient will say, well, my urine is foamy, and we'll do repeat testing and there is no protein. And I will say, well, that just means that your bladder stream is good and you're expelling your urine at a strong force such that the air bubbles are popping up and you're doing okay. The most common reason why I see patients in clinic for urine protein is when they do have chronic conditions, as I mentioned, like diabetes. One of the earliest signs of diabetes affecting multiple organs on the cardiovascular scale outside of heart disease, maybe cerebrovascular disease, is urine microalbuminuria. And that is the specific form of urine protein, microalbumin, that can leak from diabetic kidney disease. So typically now these days, your endocrinologists, your internists, for anybody who's pre-diabetic or worse, they're screening these. And the earlier they catch these, the earlier I see them. And then we utilize goal-directed management therapy combined with nutritional changes and a multidisciplinary approach to try to lower that. Because the lower the protein, the better the prognosis for the kidneys long term.
Yeah. You mentioned a big part of your clinic is diabetic nephropathy, essentially.
Mm-hmm.
And I think that's just an interesting conversation to paint. I think it's so challenging as the physician sometimes. The benefit for us, I guess, is we're able to see the end of the road, right? See someone with early onset diabetes and we can picture 10 years, 20 years, 30 years down the line what some of those implications might be. But that's oftentimes challenging for someone in the moment to fully grasp and to understand why it might be helpful to implement some of these lifestyle changes. So there are cardiovascular risk factors that we see with longstanding diabetes. You talked about cerebrovascular risk factors. As a neuroradiologist, I see a lot of chronic microvascular ischemia, right? That's oftentimes seen in the diabetic population, more so than other populations. What happens with the kidneys specifically in relation to diabetes?
So when I educate patients, and I think, as you mentioned, it is a challenge because usually when they see me, they haven't felt these serious symptoms, right? The episode of angina and abnormal EKG leading to a stent, a change in mentation leading to a stat CT or MRI, or sudden changes in urine output with swelling and electrolyte abnormalities. They're not there yet. So when they come and see me, they always tell me, well, doctor, I feel okay. How do you know something is going wrong? And why are you so worried? So what I tell them to imagine themselves at is flowing through their own blood and the way the kidneys filter your blood. Kidneys across just about most genetic backgrounds have a maximum saturation point for glucose. It's called the TMP max. And that's essentially the maximum amount of glucose that can go between the blood, the urinary space, and back and forth. And that's about 180 milligrams per deciliter. That would be your point of care glucose of 180 or lower. When we go above 180, that's when you start getting those N-glycation products, or as people like to mention, their A1C, that's measured over 3 months. So when you're persistently above 180, even with maybe spikes, maybe not persistently, when that goes for months, years, and somebody's protein starts to pick up, what we mean is those N-glycation products have affected the microscopic circulatory system and membranes within your kidney and has caused them to become porous. So it's like a filter system in any other mechanical object that's starting to have little micro leaks throughout it. And many times we'll do a biopsy and the biopsy will show, and the description will literally say onion ring or ring shaped deposition within the microcapillary bed or within the vascular bed. And if you literally look at the artery on the biopsy, it looks like little onion peels that have stuck to the wall. And that is what is compromising the kidney. It's really tough to reverse it. And unfortunately, if it persists, then those little layers of N-glycation products can slowly close off the kidney's arteries and eventually lead to kidney failure and lead to scarring. So that's what we try to prevent. But the hard part is patients don't feel that. There's no pain. The they don't have very many nerves outside of the capsules of the kidney itself, which is a surrounding layer. So this microscopic description that I gave is inside that layer. Typically, patients will feel pain from kidney stone, a UTI, something like that affects that capsule. But everything I just described, they won't feel it. And that's a very unique challenge. So that's what I try to do through education, but yeah, it's hard.
Yeah. And this arteriopathy, this is really systemic. This is all over, right?
Mm-hmm.
It's happening at the level of the kidneys, but this is why we see multi-organ involvement of all of these metabolic disease processes, because this is happening in the heart, this is happening in the peripheral arteries that go to the legs, and we see peripheral arterial disease. This is kind of happening everywhere, right? So, before this, you were mentioning that food in relation to health comes up maybe a little bit more in your clinic than in other areas of medicine. How does food or diet play a role in not just diabetic nephropathy, but in renal health in general?
So much of what you've discussed and with other experts in their fields, we have a abundance of very rich foods around us. And for those of us who are aware of what is around us, we are able to make those educated choices. And the best example I give in my clinic is if you're making a hamburger at home versus buying a hamburger through a drive-through. From the beginning parts of it, the meat, the bread, all parts of it, if you're making it at home, you can really dissect each macro and micro ingredient of what you're eating, and you can really control it. When you're buying it outside, yes, they may have nutrition labels online, but you have to be able to interpret those things and understand them. And unfortunately, healthcare literacy, education for food, what's in it, what's good, what's bad, how much do you actually need is very, very much lacking. Prior to entering medical school, I did a gap year in a underserved school in South Central Los Angeles. And because I was pre-med, one of the things I did was healthcare education for high schoolers, right? Obviously, as they're eating whatever they see around them because they're hungry and they're growing and it's not their fault that they're hungry. The concept of what's a calorie, what's glycemic index, what is a balanced meal, what is the content of what you're eating. These were all high school kids going to various types of post high school education, but their knowledge of their food was wildly lacking. And that unfortunately also shows up with my patients where I'm breaking down with food diaries. After they meet me, I ask them, okay, I tell them for 7 days, write down everything you ate, good, bad, or ugly. I'm not going to judge you, but I want to see what you ate. And then I show them the content of what they're eating and I correlate it to their high cholesterol, their uncontrolled A1C. And we try to find opportunities to substitute those things and to find other opportunities to help their health. But education and healthcare literacy are the biggest reason why I have to bring up the details of what people are eating because it's not that it's their fault. They just don't know. But that's something that almost is unrelatable to many of us, especially those in healthcare, because we see it around us.
Yeah, I think that's a huge premise of so much of what I'm trying to talk about is we have lost so much transparency in what we're eating, even when we're cooking, which is as close as we can get to understanding what's in our food. The backstory of those ingredients, we still don't fully understand, right? We don't know how long something has been in storage before it went to our grocery store. We don't know how long something was transported or what happened during harvest or what happened when it was being grown. All food essentially starts from something that was grown in the soil and then it gets manipulated on the way to a whole host of other things. But yeah, getting as close as you can to actually seeing what you're eating and what you're consuming is the only way that we can start taking control and start making some more informed decisions. So kudos to you for having those conversations and finding a path to try and talk about this stuff in medicine because it can get challenging.
Yeah. And the other challenge that I think is tough for a lot of us to combat is cost and availability. At that area, which was in South Central Los Angeles, you could get 4 cheeseburgers, an order of fries, and 4 sodas for $16. Now, McDonald's down the street, one chicken salad was $8. And you're in a socioeconomically challenged area where it's a pragmatic choice, right? Families are making their choices, kids are making their choices of what they can afford. So I never see the patients that it's their fault. But as you said, so much of this is multifaceted. It's where the food is coming from, how it's being treated, how it's being processed. And it's the unfortunate nature of our economics associated with it that eating healthier is expensive. And that is a difficult thing to process because our most vulnerable patients are also the ones who may not have access to the healthier, more expensive things. So yeah, I try, but I'm unfortunately very well aware of all the parts of this and the battle that my patients face to try to be healthier, even if they want to.
Yeah. It's not something that's black and white by any means, right? What is in our environment? We can't control the closest grocery store. We can't control if there even is one, right? Because that's also an area of access for a lot of people. And an impediment is that access to a variety of food or any food is initial impeding factor. And then we don't always get the luxury of even thinking about what type of food, right? That's kind of like question beyond that. But kind of along those lines, we also were talking a little bit about water. And this is such an interesting conversation because something that I think is really easily overlooked. We just drink water and maybe don't think about it. But water also has a really interesting backstory in relation to renal health. What are your thoughts on there?
So I think, and I always connect it to when Stanley Cups became popular, right? In the last couple of years, everybody's got a mug, they got something, and it's great. I'm very happy to see that. We're transitioning from plastic bottles to Stanley Cups, but I think with that has come with this almost obsession with drinking enough water and the right kind of water and what do I do at home and what do I need to buy? Water inherently that's going through all of our houses, through all of our buildings, places of business. I always like to tell our patients that it comes from a water district, right? And every water district has a different source, depending which state you're in. And the source is going to have a different content of water, right? Here in Southern California, we get a mixture of water from different aspects of the Colorado River and the Bay Area and the mountain runoff from there, from the Sierra Nevadas. I'm currently in the city of Orange, and one of my roles outside of dialysis patient role is also as a medical director for dialysis units, for 2 units. In Orange, we have an RO, reverse osmosis machine, which I'll elaborate on in our unit, that takes care of 150 patients weekly. We change the RO machine every 15 years. Down the street, less than 5 miles in the city of Santa Ana, they have an RO machine. We have to change that out every year. And that is because the water source, despite being in the same county, is different water districts. And the water content is something that we check on a monthly basis. So when I talk to patients about bottled water, their water at home, I always tell them before you invest in something very expensive, from a water softener to an alkaline machine to an RO machine, look at your water district. They have to give you annual reports. They will show you what heavy metals are in there, what heavy cations, anions are in there, what filtration systems they use, and what standard they're measuring to. Now, again, this is very state dependent, county dependent, but that is public information for each one of us. And you can find it online by your zip code and by your address. With that, then I'd like to try to help patients make their best choice. If you have quote unquote heavy water and you need a water softener for your home, I understand that too, because like when I moved into my home, all the devices were calcified and I knew that they were going to break. Makes sense. But water is very unique to where you live. And I think it's important to use that knowledge before people invest in all these fancy machines that are not cheap. Actually, RO machines can be in the thousands of dollars, and same with water softeners. The other thing that comes up with water is the quantity. And everybody very often in my clinic says, how much water do I need, doctor? Now, if you have some form of kidney issue where you have swelling or edema, obviously if you have heart failure, then you are on water restriction, and that is guided by those specific entities from the AHA, ACC, and from the KDIGO, which is the kidney guidelines. But besides that, water is also unique. There have been some discussions. For example, the Mayo Clinic has a Mayo water calculator. You can go online and take a look. And even they essentially say, well, 2 to 3 liters, depending on if you're a male or a female, but height, weight, activity, dietary intake, number of days of exercise are all important. So context for water is very important. Most of our bodies, thankfully, unless you are dealing with a neurocognitive disorder or some form of dementia, there are 2 parts in your brain that check the concentration and the viscosity of your blood. And they trigger another part of your brain, your hypothalamus, to tell you that you're thirsty. So unless you're dealing with the chronic, like I mentioned, dementia type illness, where that part of your brain may not be functioning and you don't have an intact thirst mechanism, your body will tell you when you're thirsty, and it's pretty good at it. So for most of my patients, I tell them, trust your body. Your body knows that if you're overexerting yourself, you're outside, it's a sunny, dry day, you're probably going to need more water. But if you're indoors and it's cool, you might need less. But everybody's need is different, but they don't like to hear that they should trust their own thirst receptors. But we have, and they work pretty dang well. So that's what I like to tell my patients, to trust themselves.
Yeah, there's a lot of correlation there with even food, right? Food and water, and there's so much out there in what you should be doing, but it's really hard to correlate advice for one person compared to another person. Everything is so different. Your biology is different. Your circumstances are different. Where you live is different. Your environment is different. And so when people talk about water, right, thirst is obviously one indicator that you can use. And when it comes to food, a lot of people say the conversation should be way simpler than what we try and make it, that we shouldn't try to force a particularly healthy diet. We can kind of eat things that make us feel energized if it's available to you. If you live in an area and you have the means to choose a variety of options, eat food that helps you feel energized, eat food that helps you feel satiated. So necessarily eating candy bars all the time, but this came up in a conversation earlier this week. But if you eat food and you feel well and you don't feel bogged down and you feel like that food actually nourished you, that might be something that works with your physiology and may be better to follow than a specific diet advice by someone who has a lot of money or has been putting things, on the internet. And
Right.
so getting a little bit more in tune is the cheapest and, maybe the most reliable path.
Right.
But going back to RO, what is RO? And then what else should we be looking at? I mean, you mentioned heavy metals as a potential contaminant in water. What else does water carry in it?
So RO, or reverse osmosis, and I want to make sure I get it right. So I made sure I got the exact definition, but it's water purification through a semi-permeable membrane. So it's not quite simply filtering water through it, but the membrane has very, very small pores to essentially only allow H2O to go through, which is a very small molecule, and it collects most of your contaminants. What I mean contaminants, it's in segments. So there's a sediment pre-filter, which is the initial run. So for anybody who has an RO machine at home or has seen them, there are multiple kind of containers. The first one is the sediment one, and that is for your bulkier toxins, your dirt, sand. And in that first one is the rust or heavy metals. Now, heavy metals is an interesting word because every area is different. I can say, for example, for Southern California, we get a lot of content here related to selenium, manganese, magnesium, and obviously calcium isn't considered a heavy metal, but there can be higher levels of calcium present due to the source of the water, depending on what type of rock and water bed it's coming out of. So that first filter will clean that. The second, which is the carbon filter, that's talking about on the more micron level, 5 to 10 micron level, that is where chlorine binds to it, negative and positive charges. Your chloramines, those are some of the more bound, smaller toxins and chemicals that may lead to bad color, bad taste, and maybe if there are additives coming in from city water or other sources. The membrane itself, as I mentioned, is doing this in each stage. The membrane is 0.001 microns of porous nature. So it's very, very, very particular, almost so particular that it actually does remove too much of some of these electrolytes. So many RO machines have a alkaline or post-filter alkalinizer to add back in some of those positively charged cat ions, like your outside of water, your calcium, and some other things that we need in our water. And then with that, there is a post-carbon polisher in most RO machines, or it's called a stage 4, and that makes it taste better. Like I said, this is when it has some alkaline product in it, usually from natural stones, or they might have some kind of stone polisher with it, and also to make sure that it looks okay. That's an RO machine. You mentioned what heavy metals to look for. It's tough. Obviously, many people know about what happened recently in Michigan and their unfortunate state of water there and the emergency that happened. For most of us, the water that's being tested and that's being sent to your house lives up to or is being checked for a certain standard of toxicity, right? I'm going to reference, for example, previously there were lead pipes. Now they were on iron pipes. Now we're on, it's like a composite material. Essentially, we're trying to remove any type of piping that brings in extra material in our drinking water and in our systems. But every area is very different. Where you get your water, what type of piping is transporting your water, how it's being stored, and then what pipes you have in your house. Each part of that could lead to accumulation of some of the things I mentioned. On top of that, adding in copper, which some may say is good, some may say it doesn't matter. It's very regional dependent. So that's what I encourage. Look at your water district. Look at what you're getting, because that's going to tell you what's in your water. And if you need an RO machine, many people don't necessarily need it, but they like the taste of the water. That's fine too. But and in other areas, you definitely need it because you're not getting adequate water depending on where you're at, or if you're in a older infrastructure or in an area where water isn't necessarily being kept as clean as maybe it should. Now, we're getting better at this, but this is regional state by state, and I'm not going to act like every agency is perfect. So I encourage everybody to look and to understand what they're getting, and then make your best educated choice.
Yeah, it really comes down to the municipalities. But with that RO filter, so the alkalization portion where we're adding things back in, is that exposure to whether it's calcium or magnesium or, whatever minerals are getting added back in? What role does that play in health? If someone's eating a pretty well-balanced diet, is that necessary? Is that helpful? Do we see any negative health effects from remineralizing water?
Right. So I think the initiation of alkalinization of water, right, or a pH closer to 9 to 9.5, that's the most marketed type of alkaline machine, was related to acid reflux. There was quite a bit of studies in the 2010s, 2000s about alkaline water helping patients with GERD and related needs to chronic acid reflux medication. And many patients attest to the fact that after alkaline water, their acid reflux went down. As per many things, after retrospective analysis, and non-inferiority studies, the data is not bad, but it also doesn't say that it helps everybody with acid reflux. But I believe that was one of the first kind of instigators of alkaline water. And then other people suggested that it may be beneficial for gut health, for your biomass. And that's when there's a little bit of controversy associated with it. Our body's pH as a whole is around 7.0 or so. Obviously, when we look at blood gases, we're talking more about a pH of about 7.35, 7.45. But that's when your blood is at homeostasis. Your gut is very different. When food reaches your stomach, it's quite low. Your pH is much more closer to 2 to 3 to break down food, and then it slowly alkalinizes in your small bowel and then continues to closer to 7 until your colon, where water is removed and you have to go to the bathroom. So the gut health with biomass, that is still being studied from what I understand. From what I have read so far, there are some reports of actually alkaline water affecting biomass in a negative way. So I myself and some of my colleagues have had patients who were otherwise being healthy, doing all the right things. They bought an alkaline water machine and they ended up getting oral candidiasis, oropharyngeal candidiasis and esophagitis, because the pH was not what their body liked. And this goes back to previous parts of our discussion, that if you're eating well, if you're getting adequate hydration, and you're not suffering through any side effects of your hydration, alkalinization may not be necessary. But if it's being medically recommended to you, given your context of your health, maybe you do have acid reflux, maybe you have some other type of medical issue that it can benefit, that's very different. But the data is still on the fence in terms of its true benefit, because it's also not cheap. And that's where I always struggle with patients, because I try my best to never recommend things where they're paying out of their pocket. Our patients pay enough for insurance, they pay enough for medications. As a clinician, I always try to utilize their benefits that they're already paying for, and paying for something out of pocket, like an alkaline machine for home or buying alkaline water outside, really needs to have medical justification. And I so far haven't really found one that's objectively far superior with very little risk to their health. But that's what I know so far. I think open evidence continues to update this every day. So if I see more, I'm open to it. But that's what we know so far.
Yeah. Any thoughts on hydrogen water?
I haven't read too much about hydrogen water. I mean, that one I got to look up.
Yeah. I have come across it a little bit in like the integrative oncology space.
Okay.
But haven't seen much in terms of like hard data or anything that seems like compelling, I guess. But same thing. If I read more, there's always new stuff coming out all the time. Then open to it. But
Yeah.
just wondering if
Yeah.
you
That's great to bring up. I need to look it up. I never heard about it before.
Yeah. Okay. So electrolytes.
Mm.
That's also something that comes up all the time. A lot of people are utilizing. Do you have any thoughts on people adding electrolytes to their water?
Yeah, a lot. So, Gatorade, technically being our first electrolyte water, right, was created in Gainesville, Florida, because it's humid and hot, and their athletes were sweating out their electrolytes, right? Especially chloride, sodium, magnesium, and they were getting dehydrated and having low blood sugar. Gatorade makes a heck of a lot of sense for those athletes down there. And these days, now we have liquid IV, there's LMNT, there's none, Propel Zero, Gatorade Zero. I can go on and on. They're useful in context. And I feel like I keep going to that in context because the food that we're getting on a daily basis combined with adequate hydration usually is enough unless you have a change in your activity. And what I always like to present as an example is if you're going on a weekend hike, there are hikes that are walks that you can maybe take a sandwich or a banana and you're fine. And there's a hike that I remember so clearly when I was in medical school in Arizona, and it's called Flatiron. It's about a 4,000 foot gain over 4 miles. And it's a hard hike. Now, that context of being on a difficult level of physical exertion, sweating, maybe unable to eat a full meal in the middle requires electrolytes, right? Whether you're taking it in via powders with water. I know Gatorade has these gummies or jellies now you can chomp down on. Makes a lot of sense. But those of us going to work, going to the office, even going to the gym, again, you're going to the gym, but if you've had your 2 or 3 meals a day, you don't necessarily need so much electrolyte in your water because many of these powders have quite a bit of sodium. Liquid IV, for example, I think is about 650 milligrams of sodium per packet, 500 to 650. I know LMNT is close to 1,000. Don't quote me. But it's quite a bit of salt. You need to be expelling that salt to justify taking it in. Otherwise, you're not really getting a benefit. And if anything, it might just increase your blood pressure given the sudden shot of salt into your body. So I always emphasize with patients, if you are a pro athlete, you're a trainer or something, then definitely you might need it. And if you take it and if you feel better with it during your activity or after, that's your best test. But you don't necessarily need it. If you're otherwise getting enough food and you're snacking on things after your workouts, whether it's fruits that are electrolyte rich or you're eating a meal, then you're going to get your nutrients through that. But it's a huge market. And I think everybody almost kind of falls for it because the marketing is so good. And I don't blame them. Like they taste good. The bottles look great. They have every flavor under the moon. And it's not expensive enough of a barrier of entry for patients to try it. So yeah, it's always, if it helps you during your exercise, great. If not, you don't really need them if you're getting enough food.
Yeah, awesome. Additives. Are there any particular additives or things that you think affect the kidneys or just health in general that people should be aware of and think about?
Yeah. So one thing that has happened since COVID is the supplement industry in particular has exploded around us, and that has caused a unique issue. Now, additives themselves, truthfully, haven't been shown to necessarily cause direct kidney injury unless the levels are very high. But supplements, we're starting to see them. Many people, and to give them benefit of the doubt, out of benevolent and philanthropic ideas, created a lot of tonics or pills that had higher doses of things like vitamin C, vitamin D. And at the time, there wasn't necessarily a correlation or thought with many of these things for toxicity and what it can cause. And with this supplement industry, the other part of it has also been things that are not studied in terms of even like a material safety data sheet, in terms of a chemical compound or a risk benefits sheet that you get from a pharmacy. I've had, unfortunately, a couple cases during my training and afterwards where patients bought a Dr. So-and-so's something fluid or prevent COVID, prevent flu, and they ended up on dialysis because of what they were taking.
Jeez.
We would, they come in, they have no relevant medical history. Their kidney function is below 10. They're not making enough urine. They're in the ICU, and you do a biopsy and all you see is reactive inflammation and neutrophils on their biopsies. You don't even see crystalline deposition. There's no, other issues like related to diabetes where you see arteriolynosis or hyaline deposition. You don't see anything. It's just inflamed. And you try to give them steroids to reverse inflammation. But the struggle is you don't know what you're targeting with steroids. And steroids themselves are not a benign medication. There's a dozen of side effects, but you try to knock this out and it still doesn't work. And then they get scarred over. And we didn't have an answer. And it's put quite a bit of fear in myself in terms of these things that are so well marketed, and patients I feel for them because they're just trying to be healthy. Our communities, our people, they just want to make good decisions, and they see something that's being told that's going to help them, and it's almost predatory to a point. And then these things actually cause harm. And I can't even tell them after the 20, 30 things that was in that tablet what caused it. So I always emphasize with my clinic patients, if you don't need it and you haven't had a risk benefit discussion with your physicians and your pharmacist, think twice before taking it, because even Tylenol, Advil, they have side effects. At least I can give you a list of them. For many of these things, I can't even tell you what could happen, even the 0.1% chance. Yeah, it's really challenging, and not knocking our colleagues, but there is a whole shift in this preventing aging and longevity and functional medicine. And I've started to see some of these clinics utilize these cocktails. And then I get referrals for acute kidney injury, chronic kidney disease. And I cannot confidently tell the patient what's causing it because there's so many things in there. So the eating your nutrients and supplements is much better, assuming you know what's in them, than maybe taking these things. It's scary. I feel for patients.
Yeah. I think it's an interesting conversation and something that should be talked about a little bit more. The supplement industry, I think most people, or some people at least, are aware it's not FDA approved, right? They don't go through the same process. There is, I feel like, this era of almost demonization of pharmaceuticals, and pharmaceuticals have issues. Of course, nothing is perfect, but the process to create a pharmaceutical drug is incredibly rigorous. And from a physician and prescription standpoint, I am much more comfortable to prescribe something like Advil or Tylenol because I know exactly what to look for. I know exactly which patient shouldn't be getting it. I know how much it is. And I feel pretty confident that one pill has the same formulary than the next pill in the bottle, and that one bottle has the same formulary than the next one on the shelf. And there's nothing like that in the supplement world. And I think that's also where some of this challenge is. I mean, we're talking about end-stage kidney disease, right? And a lifetime of dialysis, a completely different life for that person due to a supplement. And I mean, there are many anecdotes. Personally was involved in a case of acute liver failure, right? And someone needing a transplant in relation to a supplement. But you can't necessarily demonize that class of supplements either, because that bottle could have had something totally different in it than another bottle. So we can't even say it's the, X, Y, and Z, whatever it is, the ashwagandha, the milk thistle, the extract, the peppermint, whatever people are taking. That's not really the problem, but it's more so the fact that I don't know what's in there. And if you've taken something with pretty good efficacy, let's say you symptomatically improved and you get another bottle, I just don't feel comfortable that next bottle is going to have the same effect. Or maybe there's some compounding dose effect that, is underlying that we're not really testing for. And so some people, will get labs a little bit more frequently, right? It's like kind of wondering if there's any underlying issues that are boiling up, but that's not something that's routinely done. I don't even think that's going to catch everything.
Nope. Right.
And so the dysregulation and the lack of regulation is the concern, even more so than whatever the supplement actually is.
Yep.
And so there are some companies, I think, we're seeing some shift where some companies are now treating supplements similar to pharmaceutical drugs, where we're testing for dose, we're testing for safety, we're testing for efficacy. Those three things are missing from the vast majority of products on the market.
Right.
And so maybe there's a move in the right direction, but if that's not the product that you're taking, it's challenging to have a conversation. And I think really important to talk about, because most people probably are not aware that we are seeing patients in the ICU. We're seeing patients in intensive care units with really severe disease in relation to something that was preventable. And that's kind of the whole point of, this podcast and what I'm doing is what are things that we're doing in our lives that we could change to then change our downstream effects, right? To mitigate some of the stuff that we see. And so that's an easy one, at least.
Yeah.
And it's a tough conversation because we're also in this area where, people in general seem to not be feeling optimal. People don't feel well. There's all these things about, hey, I'm tired. I don't feel, super energized. And it's natural to turn to something, right? To want an answer and to want to figure it out. And there's not a blood test that physicians can do to point to one specific reason and give you a magic pill. And I think as we've discussed, it's so much more convoluted than that, right? It's sleep, it's movement, it's eating real food, it's having good, social connections and finding meaning in life and so many other things that lead to an overall healthy life and people feeling more vibrant. And so it makes sense to turn to supplements. It makes sense when sometimes the supplements make us feel a little bit better. But we also really need to have that risk benefit analysis conversation and understand what are some of the downstream effects of these potential things that we see.
Yeah. No, I mean, I couldn't, nobody could say it any better. It's, patients want to feel better, and I love that. I love that they want to try, they're really motivated to change their lives. They don't want, especially as a kidney doctor, I never want a patient to end up on dialysis, right? I want their GFR to get better. I want to say, sayonara, I'll see you at the local market. I hope I never see you in clinic again. That's a best case scenario, but it's so, so tough. And every patient, every context, everybody's diet is so unique. And no one rule is ever going to fit all, especially sometimes I think our data here is compared to a lot of other countries. And I have to even remind myself, let alone some of my colleagues, that we're a melting pot here. You go to any large metropolitan, our data and our population, we are not homogenous. We're very unlike most countries. Most countries, there may be some heterogeneity, but for the most part, your demographics are a large population from one background. And then smaller scattered pieces. But for example, being in LA County and being in Orange County, between where I was raised and where I live now, it's a huge melting pot. I would argue that we're so many generations in between a mixture of Latinx and Southeast Asian and people who are already here. And on top of that, your native population from LA, you almost can't point a finger at what is the average. You have to take it by pocket, by area, by city, and then contextualize even your recommendations from public health, from city recommendations, right? Things have changed. Populations have shifted. It's so, so unique, but that gets missed in a lot of ways. And yeah, this stuff is challenged.
Yeah, I think also just points to at least this concept that if there's someone out there telling you to consume X products because it made them feel better, I think just take a step back because their physiology at baseline is different than yours. Their circumstances are probably different than yours. Their environment is probably different than yours. The municipality where they're getting their water right is probably different than yours. There's so many factors. And I think that's why working with your clinician specifically to kind of delve into your risk factors, your symptomatology is required we need a little bit more of an individualized approach. And I think there's just a lot of challenge with thinking that someone who has solved a problem is going to be able to replicate that on a global scale. I don't think that exists. Everyone is different.
Yeah, and it shouldn't. We shouldn't apply one answer for every question, right? If we all answered C for every Scantron exam we had, none of us would be here. Every question's got a different answer. So yeah, it in a way, I'm glad there's patients asking for answers and asking for help. I think that's makes me hopeful, but we have a lot of work to do. And as an industry, we have to help them more, however much we can. There are obviously a lot of things that are out of our control as clinicians to help them, but one patient at a time.
Yeah.
You just hope you keep trying.
I'm glad you brought up Scantrons. Do you think our kids are going to know what that is?
It's funny you say that. So at least at my undergrad, and I'm sure it might be happening at yours, they are removing all forms of e-testing, actually.
Ooh,
Yeah.
really?
So my alma mater in San Diego, they had kind of gone towards like a computer-based test. And then with AI and all that mumbo jumbo, people started cheating. So they have gone back to, for us, it was blue books, your handwritten exams, and they actually will write their answers in the blue books.
Wow.
Yeah. And
Fascinating.
it's paper, pencil, and pen.
Okay.
Yeah.
Interesting. No, I was not aware.
Yeah.
So
At least I read that in the University of California system.
yeah.
That's a big shift.
Interesting.
Yeah. So maybe they will. I don't know. I doubt it though.
Kind of to go back to testing, is there any value in testing for cystatin C versus like a creatinine or GFR?
Yes, great question. So Cystatin C as a test is fairly new. It's been out for a while, but it's becoming much more available. 10 years ago, LabCorp, Quest may not have had them. You had to go to your large scale medical centers, your UT Southwesterns, Mayos, Clevelands, UCLAs, USCs, etc. Now you can get outside pretty often. Creatinine, which is our main factor outside of age and gender in the CKD epi equation, which is what we utilize to calculate GFR or your kidney functional percentage, glomerular filtration rate, is not perfect, right? Creatinine fluctuates depending on activity, time of the day, fluid intake. I always give my own example. As a fellow, my PCP happened to be my attending. Happened to be checking my labs. So I got routine labs done and I'd gone to the gym an hour before and I forgot that my creatinine will go up after lifting weights. So my attending called me and said, "What did you do? Why your labs look so weird?" He said, "Did you lift weights?" I said, "Yes." He said, "Go do them again." 12 hours later. And then my renal function came back. But creatinine was at its source studied off of a relatively homogeneous population when it was put into practice. It unfortunately utilized a average size population of your 70 to 80 kg male and 50 to 60 kg female relatively. And it was not diverse in terms of the genetic basis of populations that it studied when it was put into practice. So that's already a limitation factor as it is. Now, as anybody can see around us, we're getting bigger, taller, and we're also living longer. And I mentioned both because during my training, we would do physicals on a lot of our Division I athletes. And they are bigger and taller than just about anybody else around. And their creatinine, which is a base product of muscle activity, was always high. But there are 18, 19, 20-year-old, very exceptionally healthy young adult. So Cystatin C thankfully removes the use of creatinine and utilizes essentially cell metabolism as its marker. So if you are very active, if you do some type of physical exertion as part of your profession, that may be one reason to use Cystatin C because creatinine may not be accurate given your day-to-day basis. Or if you're simply a larger person, you're above average height, or if necessarily you have above average muscle mass, bodybuilding and utilizing things to get yoked or get large is a huge trend right now. And with more muscle mass, again, the CKD epi equation will underestimate your kidney function because you're going to have higher creatinine than most, given the context of how creatinine was measured. So in that context, Cystatin C also works. The other population that it works in is in your more petite, usually your elderly population that has a relatively lower muscle mass because they're not eating as much high protein foods, they're not as active. And in that population, creatinine can actually overestimate their GFR because their muscle mass is relatively lower. And again, this isn't necessarily true for every subsect of our population, but in particular, what I've seen is in your very elderly, maybe more feeble population, their muscle mass is low. But if you look at their GFR, it may be like 120 because their creatinine is so low. But if you check a Cystatin C, that's going to give you a much more realistic aspect of their filtration. So it's helpful. I check it very often, especially if it's a referral where it's like a one-off of somebody who is back in the gym for a couple months and their creatinine went up. Now, with this always comes people taking creatine, and that's always a question that I get asked. Normal amounts of creatine, which is relatively measured at a lot of supplement stores, is not going to affect creatinine per se. Now, if you're taking larger amounts, it can cause some convolution in testing, but it's an aside.
Is
But yes, that is great. What was that?
Is like 5 to 10, like low.
Yeah, it's about
Just higher
5 grams a scoop, I believe is the average. I've never taken it, but I've seen the bottles. But Cystatin C is very, very helpful. If it's available around for even not the context that I mentioned, right? Either exceptionally active, younger, larger framed folks, or maybe you're more petite, smaller frame folks, even if you're in the middle of that, it doesn't hurt to have the extra data because we do have a CKD epi, creatinine, Cystatin C combined GFR equation that is a little more robust. So I check it very often, but many times patients have never heard of it and the doctors have never ordered it before. So yeah.
You mentioned protein intake. This is kind of a tangent of that, but any thoughts on sort of this new hype of increased protein intake being?
It's so funny. I just had this conversation on an airport last week with a clinician who happened to be seated behind me on the plane. Protein is such a challenge, right? It is our de novo, I think, fad nutrient, I want to say. And there is a lot of great data behind it. I don't want to knock any of it. I think much of our, say, maybe pre-made or processed foods definitely don't have enough of it. And that has a lot more other stuff in it that is not good for you. So for the population that has to eat those things that maybe can't make things at home, looking towards higher protein foods is incredible. It's better than you can try to do. At least maybe you're having less highly processed carbohydrates. But the protein conversation that I always have is relative to chronic kidney disease and then overall intake. From a clinical perspective in the hospital, right, we look at protein depending on context of care. The most sickest patients, they need the most caloric intake and they need the most protein. So your metric is higher, at least 1.2 grams per kg. Otherwise, it's about 0.6 to 0.8, give or take. If you look at online sources, they'll say, some sources will say half of your weight should be your grams in protein in kgs. Some will say 1 to 2 times your weight. There's all sorts of information online. It goes back to, as we've talked about so often, your context, right? Your level of activity, what also makes you feel good in terms of your day-to-day basis. And I think satiation is a big part of that with protein, right? There are forms of protein that say that they have 30, 40, 50 grams in it, but you're not going to feel full. So don't know if that's necessarily helping you in any manner outside of telling you that you took the protein, because protein is supposed to be part of a balanced diet. And the beauty of protein, if you're taking it the right way, is it should keep you full. It should allow your body to process food slowly, allow your body to absorb things slower, and hopefully maybe reduce, if you're eating enough of it, the goal would be to reduce the chips, the candy, the whatever, right? That's what we all like to think about protein. But that's not necessarily true for everybody, right? How much protein you need, how you're taking it in, and is it making you feel good? Because also, if you're eating a steak per day, many of us would argue it's not going to be beneficial for other reasons. So it's a challenge. Patients like to tell me, I take 120 grams a day, I take 200 grams a day. And I said, I don't know if you need that much. Like, yes, if you're a prime bodybuilder and you're lifting hundreds of pounds of weight, you probably need a lot because you're really, really breaking down the muscle and you need more protein in your diet to build it up. But the rest of us going to the gym, going to work, we don't necessarily need so much. The difficulty is there isn't that much data in terms of protein hurting kidneys, except if you have CKD stage 4 or 5, then too much protein can be harmful. And also if it's too much protein in the context of not enough fluid intake. That's the only data I actually have. So I can't tell a patient, don't do it. I can only tell them, I don't know if you need it.
Yeah. Yeah.
Yeah.
That's awesome. Is there anything else that you're seeing in clinic that I haven't asked you about, or anything that you see contributes to kidney disease from like a lifestyle choice or kind of habit standpoint?
No, I mean, we hit on most of them. The other things, it's really tough for autoimmune conditions, right? That's that last branch of things that
Yeah.
I see.
Yeah, that's a
And
deep topic.
yeah, I mean, and that's it's a conference long discussion
Yeah.
of lupus and all of its sister conditions. What I always tell patients is if you have a family history for kidney things, don't ignore it. That's the one thing I always say, because we are getting better at genetic testing, but when you ask a patient, do you have any first or second degree relatives with kidney issues, especially when it has a genetic component, they tend to say yes.
Mm.
So what I always tell patients is look at your own labs when you see your PCP. If they didn't comment on it, ask them.
Mhm.
And if you want to look it up, you should look it up and be educated on your own, because you don't know till you ask.
Yeah. Amazing. This has been so insightful and so helpful. The last segment I always like to end with is kind of like a walk me through your day segment. And this isn't meant to say that we're perfect or anyone's perfect or anyone's doing anything perfectly, but it kind of, I found, helps people just gain a little bit of inspiration of things that I can be doing, or, realizing that, hey, there's all these other aspects of life where I can maybe pay a little bit of attention to. So just kind of starting with the start of your day, whether that's sleep or if you have some kind of morning routine, and if you can kind of just walk us through your day.
Sure. So having a 1-year-old, days are a little different now. Used to be a cup of coffee. Now it's a cup of coffee with warming up a bottle or warming up food. Not complaining. Very happy to do that. But I always do black coffee. Um, I find it interesting because I think coffee is also such a debatable thing, but black coffee was one of the ways I always try to cut out unnecessary calories because of creamer and sugar. So I always do 1 cup of black coffee, get into work, and I'm off to the ICU because ICU rounds, especially at my hospital that does kidney and pancreas transplants, we're busy. And that aspect of my job, really passionate about, helping those patients get out of whatever they're dealing with and stabilizing them. So ICU rounds are what I start with. And then typically between rounds in my afternoon clinic, some type of, and I probably sound like a hypocrite now, some type of protein thing to keep me full that helps me keep going. So whether it's like a chicken salad or it's salmon with some brown rice, some kind of thing on the go. Then I go to CKD clinic where I see my patients during the day. And then after that dialysis rounds, and then hopefully if I can, especially now that she's getting bigger, some type of weightlifting or at least 35 to 45 minutes of incline on the treadmill to, keep the body going. Because I get my steps in about 10,000 a day, but it's not the same when you're walking for work versus actually like moving to move and get your body some exercise. And then, it's time with the kiddo.
Awesome.
Yeah.
Awesome.
Not too eventful, but it's great for me.
No, it's good. I mean, it's always really fascinating to understand, right? Where can I get that movement in? How can I fit whole foods into my day? What about sleep? Any sleep related habits or things? And if not, I think that's another piece that's really challenging.
It is. I struggle, or I struggled. I'm getting better with sleep. Not to anybody's fault, but I finished my training right at June 2022. So my last 2 years of training were during COVID. We were working hours that essentially were maximum limit for ACGME every week. The patient load was not like a trickle. It was like a fire hose in terms of learning because of how sick patients were. And with that, my pager never stopped. So since training up until recently, I've actually almost had an issue of hearing like phantom pages when I'm sleeping and literally waking up to nothing. So now that I've gotten better, my sleep hygiene is something very important to me. So when I'm not on call at home, my phone goes in a different room. Don't have a TV in my room. We have blackout shutters. There's no stimulation. The only thing I have is a book. And if I decide to read a book, it's a book that's not necessarily related to work, whether it's parenthood or some type of nonfiction, whatever. That's the only thing I have in my room. There's nothing to stimulate me because I realize how important sleep hygiene is. And sleep is so important. And you arguably know this better than I do. Cortisol levels, your blood pressure, your body's circadian rhythm, appetite, going with that like snacking, glycemic, and your needs for sugar. I mean, it goes on and on and on that if you don't get enough sleep, you're not going to do well. So I've struggled with it since training, but I'm getting better at it, especially now that my daughter's sleeping through the night too. That helps. Yeah, but it's hard.
Yeah.
I'm not good at it.
Yeah, I think that's actually a really common phenomenon. I think, especially the years after intern year for a little while, because it wasn't just the pager going off. It was like the pager going off to a code blue. So I could be like in a dead sleep, right? Just totally exhausted for the day. You were there all day and then you're there overnight and then you're running. Or, I mean, even what was more jarring was like the rapids. Because with the rapids, you don't know what's going on and you have to figure it out. And it could be someone typically acutely, incredibly sick. And I think that 0 to 100 is really challenging. And then I think even for me, for years after that, when I would wake up, I think I would like wake up fully as opposed to wake up and be able to go back to sleep. And so, I think that's an area that a lot of us could probably talk a lot more about. But
no. Yoga, reading, all that. I'm trying. It's been a challenge. Yeah, but that's definitely one part of my many things I need to work on.
Awesome. Well, thank you so much. Thank you for being on. Thank you for all the amazing things that you talked about. There's so much I think that people can absorb from there, and hopefully, the idea here is to try to mitigate all the stuff that we see in practice. So hopefully, one step at a time, one person at a time.
Yeah, to anybody listening, watching, all I can say is, if I mentioned anything that you may or may not be doing, that's not good or bad. I don't mean anything negative, but everybody's body is different. And all I can emphasize is just listen to yourself, listen to your body and do what feels best because you know yourself better than anybody else. But that's a unique challenge we face, right? With all the information and all the things we're trying to help our patients through. But I'm very grateful to be on here. And again, as I mentioned, I'm super excited to see where this goes. And I think hopefully with input from so many other experts who know a lot more about what they're doing than I do, we can keep helping patients out.
Awesome. Well, thank you so much for contributing, and I'm so excited to keep chatting and keep hopefully having so many more fun conversations along the way. So thank you. Thanks for all the work that you do.
You too. Thanks.
Thanks for tuning in to Dive into Health MD. Our goal is to empower you with knowledge to better understand how your daily choices influence your health. If you enjoyed this episode, consider sharing it and subscribing so you don't miss what's next. Please remember, this podcast is intended for educational purposes only and should not be considered medical advice. For personalized guidance, always consult your physician or a qualified healthcare professional. Wishing you physical, cognitive, and financial wealth. See you in the next episode.